Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Welcome, everyone. It's my pleasure to welcome you today to the Medscape Global Oncology Program, a year in review of antibody-drug conjugates for breast cancer. We'll be focusing on trends, relevant stuff for practice, and the outlook where we're heading in the next few years. My name is Peter Schmidt. I'm a medical oncologist and work at Barts Hospital in London. So a pleasure today to have a fantastic faculty joining me for this program. Dr. Shanu Modi from Memorial Sloan Kettering Hospital, Dr. Erica Hamilton from Sarah Cannon Research Institute, and Dr. Nicola Fusco from the University of Milan, the Division of Pathology. If you briefly look at the agenda, you're already done pretty much with my welcome and introduction. We will then move on to Shanu and Nicola together looking at HER2-positive, ER-positive, HER2-low metastatic breast cancer. How are we expanding options with antibody-drug conjugates? Then we will move on to Erica Hamilton, who will talk about ER-positive and HER2-negative or HER2-zero metastatic breast cancer, integrating ADCs into the evolving landscape. Shanu will then talk about HER2-positive metastatic breast cancer, new insights on ADCs, and I will round this up with some thoughts on where we're heading with ADCs in the breast cancer treatment. There will hopefully be plenty of time for a Q&A session at the end, and I would like to encourage you to submit your questions through the chat option. The more you participate, the more interactive it is, the more fun it will be ultimately for all of us. Without further ado, I would now like to hand over to Shanu Modi and Nicola Fusco, who will be talking about ER-positive, HER2-low metastatic breast cancer. Shanu, over to you, please.
Shown here are the current ESMO guidelines for treating hormone-positive, HER2-negative metastatic breast cancer, where many of you know our preferred strategy is to really use endocrine therapy, particularly in combinations, until such point that the tumors become refractory to endocrine treatments, at which point we move to sequential single-agent chemotherapy. And this is really the setting where we've introduced antibody-drug conjugates based on a number of randomized phase 3 studies that have shown that they produce superior efficacy and survival advantage compared to our standard chemotherapy drugs. So if you look at the bottom right box, for after 1 or 2 lines of chemotherapy for those patients who have HER2-low breast cancers, our preferred antibody-drug conjugate today is trastuzumab deruxtecan, also called T-DXd, and this was based on the DESTINY-Breast04 trial, which did show a survival advantage to T-DXd versus standard chemotherapy drugs. So the exciting news from last year, of course, was the DESTINY-Breast06 trial, and this is really a follow-up phase 3 study to DESTINY-4. Again, it's comparing T-DXd versus standard of care chemotherapy in hormone-positive, HER2-low metastatic breast cancer, but in an earlier line setting. So these are patients who have not had any prior chemotherapy, and we're using this therapy after endocrine treatment as the first systemic treatment. And as shown here in the primary endpoint PFS curves, again, a clear advantage for T-DXd, hazard ratio of 0.62. The median PFS with chemo was 8.1 months, moving up to 13 months with T-DXd. That's an absolute delta of 5 months. One of the other things, besides looking at an earlier line setting, that the DESTINY-Breast06 did was also to look at a broader population of patients. And so the study also included an exploratory cohort of patients with HER2 ultra-low breast cancer, which we define as IHC scores of 0+, or basically any staining in any number of cells. And as shown here now in the PFS curves for the intent to treat population now, including the HER2 low and the ultra low population, again, you see the results are nearly identical. Hazard ratio is 0.63, and the mean in PFS improved from 8 to 13 months. And these are very exciting. They're the first randomized data we have for TDX, positive data for TDXD in HER2 ultra low breast cancer. Overall survival was a key secondary endpoint of that trial, and as shown here on the left are the HER2 low curves, and on the right for the ITT population. This was an interim analysis, and there was only 40% data maturity at this point of presentation. But you can definitely see that there is a trend in favor of TDXD. I think if you look at the 12-month overall survival rate, it's about 88% with TDXD versus 82% with chemotherapy. Important to point out that about 20% of the patients on the chemotherapy arm did cross over to receive TDXD, and likely there are other patients who've received sacituzumab and potentially datopotamab. And these numbers, I believe, will increase with further follow-up. And so it is quite possible that we may not see an overall survival advantage in this study, unlike the DESTINY-Breast04. This is an interesting exploratory analysis looking at progression-free survival in endocrine-resistant subgroups. So on the top left, you can see that regardless of the prior benefit or time to progression on endocrine treatment, whether it was less than 6 months or greater than 12 months, in all cases, TDXD really outperforms standard chemotherapy. And I think this is most prominent in the very endocrine refractory cancers and those where there's less than 6 months benefit on CDK4/6 inhibitor and endocrine treatment, where standard chemo actually performs quite poorly. On the bottom row, you see, regardless of whether there's primary endocrine resistance or secondary endocrine resistance, again, in all cases, there's an advantage for TDXD. With regards to the safety profile, there were really no new findings in DESTINY-6. I mean, on the left, I will point out that overall, there's a lower rate of nausea, and particularly high-grade nausea in this trial compared to other TDXD studies. And I think that's likely related to the fact that it's now standard to give these patients really potent antiemetic therapy prophylactically. On the right, you see the profile for the control arms, and about 60% of the patients on the study got capecitabine. In the chemotherapy arm, 40% got paclitaxel or nab-paclitaxel. So the side effect profile is what we would expect for those types of chemo drugs. And overall, I think there is less toxicity in general with standard chemotherapy. So a bit of a trade-off for the improved efficacy. With regards to ILD, the overall incidence was 11% in DESTINY-6 and less than 1% incidence of grade 5 events, similar to other trials in the modern era. LV dysfunction, I mean, it was largely low grade, and there were no cases of cardiac failure. And so overall, I mean, I think these data really nicely support a broader, more expanded role for TDXD and in a larger population of patients as an earlier line setting. And interestingly, yesterday, the FDA in the US just expanded the label for TDXD based on these DESTINY-Breast06 data. So there are, of course, other ADCs in development for HER2-low breast cancer, sort of following on the heels of TDXD. One such drug is BB1701. In this case, the backbone is a trastuzumab-like monoclonal antibody. This ADC has a cleavable linker and an eribulin payload with a DAR of 4. And based on a very promising phase 1 study, there is now an ongoing phase 2 trial looking at BB1701 in patients with HER2-low metastatic breast cancer, as well as HER2-positive metastatic breast cancer in patients who have had prior TDXD. So a really important study, I think, to keep on your radar. And with that, I'm going to hand the platform over to Dr. Fusco to talk about HER2 testing.
Thank you, Shanu, for giving us this outstanding overview of the clinical rationale for the opportunities provided by antibody-drug conjugates in the treatment of breast cancer. And actually, in 2024, we have reinforced the role of HER2 testing in pathology for patient selection. And now we have to deploy into the clinical practice the guidelines that have basically not changed in their evaluation for HER2, including the assay and the histopathological evaluation. But what has changed, as you explained very well, is the clinical rationale for the testing. So we all know very well that HER2 positive breast cancer are those that basically have an amplification of HER2. And all of the other tumors have historically been considered HER2 negative, but actually HER2, given that it is a biomarker, immunohistochemical biomarker, represents a spectrum of expression, both in terms of staining intensity, but also in terms of percentage of positive tumor cells. And that's why the immunohistochemical evaluation requires a scoring that ranges from 0 to 3+, where the 3+ is the proxy for the HER2 amplification. The HER2 low tumors are considered those with score 1+ or 2+ with no amplification of the gene by an in situ hybridization assay. And these are the subgroup of HER2 low. And this represent in the clinical practice approximately 50–55% of cases. However, also in the immunohistochemical score 0, we have a spectrum of patients, those with completely no staining using an HER2 validated immunohistochemical assay, or those with a faint or barely perceptible membrane staining in less or equal than 10% of the tumor cells. So this HER2 score 0 with HER2 expression less than 10% of tumor cells are belong to the ultra low family. So in this respect, the spectrum of expression is extremely heterogeneous, both in terms of spectra expression, but also in terms of patients. And indeed, there are many variables that can affect the HER2 testing. And these are not only related to the tumor biology that is by itself already extremely complex, but it's also related to the different phases of a testing, predictive pathology testing. So we have the pre-analytical phase that represents a crucial step with many variables, including the time of cold ischemia, but also the protocols for tissue fixation, the tissue processing and the embedding. So all of these variables can affect tremendously HER2 testing, and that's why to deploy in the clinical practice an optimal HER2 testing, it's extremely important that all of the steps for the pre-analytical phase into the pathology lab are fully under control with certification and internal and external quality assessment. Then we have the actual HER2 testing process that is also extremely important. And we have the possibility of choosing different assays, even though the 4B5 assay is that is being used in the clinical trials, but we have also the need for an harmonization of the staining platform. All of this this variable can affect particularly the identification of the HER2 ultra-low cases. And then, of course, we have the post-analytical phase that is extremely complex and requires, of course, quality control, pathologist training, continuous training and update to increase the sensitivity and the specificity, that is to say, the predictivity of HER2 testing. It's extremely important that the network of pathologists at the local level, but also at the international level, is reinforced using training and possibility of exchange opinions and doubts. This is the key to increase the quality of the testing. But of course, the quality of the testing requires also a synoptic pathology report that is in compliance with the ASCO updated guidelines and the ESMO updated guidelines for testing and reporting, that basically do not change the analytical scenario, but they change the way in which this type of testing affect the patient journey. So it is extremely important, for example, to retest the historical samples that have been previously scored as score 0, not because the guidelines have changed, but because the clinical rationale have changed, and then the sensitivity of the HER2 scoring 0 back 5-10 years ago was lower than today, because today we have the approval of the drug, trastuzumab deruxtecan, and we have the clinical rationale for the identification of this subset of patients. Of course, when we report the result of the HER2 immunohistochemistry, we can no longer rely on positive versus negative. This dichotomous view is now outdated, and it's extremely important to state the specific score by immunohistochemistry, but also the pattern of expression, the staining intensity, and the percentage of positive tumor cells. These are extremely important information for the multidisciplinary discussion in the tumor board. And I think that now we have some clinical case.
Yes, thanks, Nicola. So to sort of wrap up this section, I'm going to present to you a case of a 50-year-old woman. She was a Brazilian woman, presented originally just a couple of years ago with a locally advanced breast cancer, underwent neoadjuvant chemotherapy, dosed adriamycin, cyclophosphamide, and paclitaxel. Unfortunately, had a lot of residual disease. The tumor was known to be, in the residual disease, known to be ER positive, PR low positive, and HER2 IHC 0. At that point, she went on to get adjuvant endocrine therapy with letrozole. CDK4/6 inhibitor was not available. And sadly, within 2 years, was diagnosed with a metastatic recurrence to the bones and the liver. She was quickly started now on first-line endocrine therapy with fulvestrant and abemaciclib, but had a very short-lived benefit. Similarly, or I should say, she did have sequencing done, and there were no other actionable mutations. So she was then moved on to chemotherapy, starting with capecitabine, followed by weekly paclitaxel. But she really had very, very short benefit. And at this point, these are her liver scans. You can see she has really extensive involvement with liver metastases, and this is her dominant site of disease. So a new liver biopsy was undertaken, confirming metastatic disease. ER was now 40%, the PR was completely negative, and the HER2 IHC score was 1+ with a Ki67 of 35%. So based on what we know today, how would you treat this patient now? And I've listed some options here, starting with TDXD, gem-carbo, eribulin, or liposomal doxorubicin. And we'll give you just a minute to answer this polling question. But I think you could see that, you know, any one of these is a reasonable option. But I do think, knowing what we know today, particularly from the DESTINY-Breast04 and the DESTINY-Breast06, this is a patient with HER2 low metastatic breast cancer and will be an ideal candidate for trastuzumab deruxtecan, which is what she went on to receive and did in fact have a tremendous response in her liver metastases. So I think, as all of you know, as clinicians, that treating breast cancer or cancer patients optimally really requires working in a multidisciplinary team. This includes not just the oncologist, but other specialists or pathologists, pulmonologists, radiation docs, etc. And that's really important when you're using therapies like trastuzumab deruxtecan. So I'm going to hand over now to Erica Hamilton to talk about hormone-positive, HER2-negative metastatic breast cancer.
Thanks so much, Shanu. So these are the ESMO guidelines for ER-positive, HER2-negative metastatic breast cancer. You can really see that our mainstay here is endocrine therapy in combination with a CDK4/6 inhibitor. For most patients, this will be an aromatase inhibitor unless they relapsed within close proximity to adjuvant AI, in which they may get something like fulvestrant. And then in the second line is really where, depending on mutation profile, we have a lot of choices. We have elacestrant for ESR1 mutations currently. For PI3 alterations, we have alpelisib, and then we also have capivasertib for PI3 AKT or PTEN alterations. Certainly always have our PARP inhibitor, and then kind of a mishmash of different options for what I like to call a bland mutational profile, including CDK combinations. We now have data from postMONARCH that abema after initial CDK can be beneficial, as well as everolimus combos. I would say initially on the top right side of the slide, I think we don't use this very often. We've had multiple trials that have really reassured us that even with liver disease, et cetera, our patients that receive chemo do not do any better. If anything, they actually do worse than receiving CDK4/6. But once we think somebody has endocrine resistance, they didn't respond to their last line of endocrine therapy well, that's really where we think about moving on to antibody-drug conjugates. So again, this is just going over the rationale for molecular testing. You'll see PI3, the AKT and PTEN additional alterations that capivasertib picks up in terms of approval, as well as ESR1 mutations for elacestrant. I think it's important to note that this can be done on tissue. It could also be done on blood. I think most of us are getting tissue at initial metastatic diagnosis, confirming that this is still ER positive and HER2 non-amplified cancer. And so we often do have tissue there. But sometimes when we think about retesting this, maybe after a CDK, it can be appropriate to use blood-based testing, particularly sequentially in this setting. So I'm going to turn it back over to Nicola to talk about pathology here.
Thank you, Erica. And indeed, in these exciting times of breast cancer oncology and predictive pathology, our work in the multidisciplinary team is becoming more and more complex. And with these raising biomarkers that have been raising biomarkers for just a couple of months, then they entered tremendously in the clinical practice. We now have to be able to test and, most importantly, to understand the clinical meaning of the biomarker testing in the metastatic setting. We have discussed previously about HER2-low, but we have now additional molecular biomarkers such as ESR1 on liquid biopsy, particularly, as you mentioned, PI3K and the PI3K pathway, including AKT1, PTEN, and the type of testing is extremely important because at first we have to decide what is the correct clinical scenario for this testing. And we know that that is the oncologist and the multidisciplinary team, the clinician, who has this will provide this information and has to request the test based on the actual opportunities of the patients. And the timing for testing is also extremely important to be able to get the most from the molecular testing, but is also a matter of biomaterials and bioanalytes for molecular testing. And in particular for breast cancer, unlike our colleagues that works, for example, in lung cancer, we are pretty much lucky because we have plenty of biomaterial to choose. Often we have the pre-surgical or pre-neoadjuvant treatment biopsy, the surgical sample, the biopsy of the metastatic site, and plasma for ctDNA testing. But these possibilities in terms of biomaterials add a layer of complexity in the choice of the most appropriate biomaterial for molecular testing. And for example, we know that some biomarkers are likely to be found in the ctDNA because they are acquired mutations, such as in the for the case of ESR1, but other cases, and in particular for the PI3K pathway, AKT1, and most importantly, PTEN, are likely to be found in all of the biomaterials that we have available in our archives. And that's because these types of mutation often occur as the fungal genetic events, and they are truncal alteration. But I want to spend just a few words about the complexity of the PI3K pathway testing that is not represented only by the fact that there are multiple genes to be tested simultaneously, but is represented also by the type of molecular alteration that target these genes. And if for PI3K and AKT1, we have point mutations that can be tested theoretically also using real-time PCR-based approaches. For PTEN, the situation is more complex because in breast cancer, yes, we can find some mutations, some inactivating mutations, but in the vast majority of cases, we have PTEN loss, the loss of the gene. And we know that a targeted approach for identification of PTEN loss is not impossible, but is more complex, extremely more complex. That's why next generation sequencing can provide the most comprehensive information about this type of testing. And of course, in this situation, the tissue is likely to give us most of the information because the ctDNA testing for PI3K and AKT1 is extremely effective, but for PTEN loss, to get the sensitivity, the higher sensitivity from the detection method using NGS in liquid biopsy, it's more complex. So again, it is extremely important to approach this type of molecular testing using a multidisciplinary discussion that takes into account various questions that ultimately lead to an optimal testing for precision oncology.
Fantastic. Thank you so much for that. I think one of the things you said really resonated with me. It's definitely layered complexity. I think we would all agree that things have gotten much more complicated for these patients after initial CDK4/6 inhibitor. So I want to just walk you through the TROPiCS-02 study. This was the phase 3 trial of sacituzumab govitecan in patients that had hormone receptor positive disease. So recall on this trial that everyone had already had an endocrine therapy, a taxane and a CDK4/6 inhibitor. they had had at least 2 lines of chemotherapy, but no more than 4 lines of chemotherapy. So think about this for an HR positive patient, they'd really gone through however many lines of endocrine therapy they were going to have, and then went on to get 2 additional lines of chemotherapy. So this is really a pretty heavily pretreated population. And they were randomized in a 1-to-1 fashion to either receive sacituzumab govitecan or treatment of physician's choice, which honestly is good chemotherapy that we routinely use: capecitabine, vinorelbine, gemcitabine, or eribulin. This is what we saw over on the left. You can see progression-free survival was lengthened with chemo from 4 months up to 5.5 months with sacituzumab govitecan. And you can see below here, progression-free survival rate, essentially only 7% of patients were progression-free at a year with chemo, but compare that to 1 in 5 patients that received sacituzumab govitecan. Over on the right, you can see overall survival, again, statistically significant, a benefit essentially from 11 up to 14 and a half months. One of the big questions is, should we be testing for TROP2, since this is a TROP2 targeted antibody drug conjugate? And this really looked at H-score across these tumors. And we saw that the progression-free survival, as well as the overall survival benefit of sacituzumab over chemotherapy, was observed regardless of TROP2 expression. There is a little bit of a hint that those with high expression may do well for even longer, but regardless whether you had high TROP2 or low TROP2 in the tumor, it beat chemotherapy. So really not something that we need to test to see who may be eligible to receive this drug. So we're moving on to TROP2 expression. Nicola, I don't know if you want to chime in and tell us a little bit about testing.
Thank you, Erika. And indeed, this is an exciting topic because this emerging biomarker is getting more and more attention, not only in terms of patient stratification for sacituzumab govitecan, but also because it has become the object of the first digital biomarker in another field, that is the non-small cell lung cancer field. And presently, we really do not have a specific assay that is approved in the clinical practice. And indeed, the response to the therapy with sacituzumab govitecan that is related to the TROP2 expression as a continuous variable does not require the use of this immunohistochemical assay into the clinical practice. And in my opinion, the adoption of this biomarker in the clinic would be extremely challenging, because we have different assays that have been used in different clinical trials using different guidelines for the evaluation. And the peculiarity of this type of biomarker is that it is an ubiquitous biomarker that is often expressed also in the normal cells. And despite the fact that the TROP2 is a membrane protein, the internalization of the receptor make also the cytoplasmic expression of TROP2 likely to be clinically relevant. But at present, we really do not have strict guidelines for assay selection and TROP2 evaluation. We have some clinical evidence about the patient stratification for patients response, for therapy response, and we have some preclinical studies that inform us how the cytoplasmic expression and the ratio between the cytoplasmic expression and the membrane expression can be used for a more accurate patient stratification. But at present, in my opinion, it is extremely important to pay attention to this biomarker and to stay updated and to train for these types of analysis. But in terms of following up the development of the clinical studies that are currently ongoing.
Fantastic. Thank you so much for that. I think we're asking more and more of our pathologists all the time. Certainly, Dr. Modi was talking about the ultra low now for HER2, and picking out those zeros that still have some expression is certainly not standard. And so something that we're working with on pathology as well. Here we see some safety information around sacituzumab govitecan, and specifically by TROP2 expression. So you can see neutropenia really did not look significantly different. We certainly do see neutropenia with sacituzumab govitecan. This can be a quite common challenge and can be a challenge in the clinic sometimes because it's given on a day 1 and day 8 interval. And so we can't use a pegylated form of growth factor in between that day 1 and day 8, but we can use it after day 8 to really boost up the counts for the next cycle. I think that's what many of us are finding easiest in the clinic. We certainly do have the option of using a short growth factor as well, or altering the schedule if we need to. Luckily, we saw, regardless of arm, that febrile neutropenia was infrequent in our patients. And then also remember that diarrhea is also another side effect that we do see with sacituzumab govitecan. And this was actually a little bit more common than we saw with traditional chemotherapy. So this was TROPION-Breast01. This was our trial of datopotamab deruxtecan, so another TROP2 targeting antibody drug conjugate. This has the same TROP2 targeting as sacituzumab govitecan, but the payload of trastuzumab deruxtecan. So I like to say that it's the baby of the two drugs. But again, another TROP2 targeting. And I think it's really important for us to recognize that all of these antibody drug conjugates, although we like to lump them in a class together, really are quite individual drugs. And even when we're talking about the same target, sacituzumab govitecan or datopotamab deruxtecan, we really see quite different side effects. So we'll briefly get into this as well. In this trial, again, we enrolled patients with hormone receptor positive breast cancer. They'd been previously treated with 1 to 2 lines of chemotherapy, and they'd had to have progressed on endocrine therapy and felt that further endocrine therapy was not suitable for that patient. Patients received either datopotamab deruxtecan, and you'll see one difference here, that this is given once every 3 weeks. So in contrast to the day 1, day 8 schedule of sacituzumab govitecan. And again, we see a very similar treatment of physician's choice, single agent chemotherapy arm in a 1-to-1 fashion. This is what we saw. We saw an improvement over chemo, giving us a 4.9 months of PFS to datopotamab, giving us 6.9 months. This was a hazard ratio of 0.63 and was significant. Overall survival is not significant yet, a little bit immature here, likely. But overall response rate, I also think is helpful for us to look at, especially when we're talking about some of these more heavily pretreated patients that may have visceral disease. And we were more likely to get an objective response with the antibody drug conjugate over chemotherapy, about 36% versus 23%. So let's dive into these adverse events a little bit. I think this is really important because a lot of these we can help prophylax and prevent these for our patients in the clinic. We just have to identify with what particular antibody drug conjugate we're using, what the common side effects are, and what we need to do for these patients. So we do see nausea still being quite prominent with this, very rare to be grade 3 or greater, but about half of our patients having some grade nausea. The other unique side effect here is stomatitis, so sores in the mouth. We can be very effective in preventing this if we use a dexamethasone mouth rinse. I typically advise my patients to do this 4 times a day if they can. This is something that we don't see, for example, with sacituzumab. We don't see with trastuzumab deruxtecan, so really a side effect unique to this antibody drug conjugate. And I really caution my patients that when they get mouth sores, it's a little bit hard to get rid of them. And so they really need to be very vigilant in using the steroid mouth rinse up front. As part of these clinical trials, a steroid mouth rinse was certainly allowed, but it was not mandated per protocol. And so it's a little bit difficult for us to tease out what the exact incidence is if patients are reliably using the steroid mouthwash in a prophylactic fashion. I also tell my patients that if they don't get mouth sores after the first week or two, to not dismiss this and think that they're not going to be a patient that has mouth sores, but to really stay on the steroid mouth rinse to prevent this. Alopecia, we can see as well with datopotamab deruxtecan. And as we see with some other antibody drug conjugates, we can see dry eye. Now, this is not the more severe eye toxicity that we see for drugs like mirvetuximab, for example. This really is predominantly just dry eye, not needing steroid eye drops or anything like that. A simple moisturizing eye drop has done just fine for my patients. You do see that neutropenia, although very prominent with sacituzumab, is not prominent at all with datopotamab. So only 10% any grade neutropenia obviously compares quite favorably with single agent chemotherapy. So this was Trophus 10. This was a phase 3 trial of sacituzumab tiromatecan. So again, as you can hear with the sacituzumab, we're talking about a TROP2 targeting drug here again. And here you see that there are 3 arms. The ADC by itself, given every 2 weeks, the ADC in combination with pembrolizumab immunotherapy, and then the control arm with single agent chemotherapy. These patients, again, all had hormone receptor positive metastatic disease. They'd had CDK4/6 inhibitor in combination with endocrine therapy, and now different, they'd had no prior chemotherapy in the metastatic setting. So this is a little bit more of a naive population in Trophus 10. So let's move on to this case. She is a 49-year-old female. She was initially diagnosed with a 2-centimeter node negative, ER very positive at 90%, PR a little bit lower at 15%, and HER2 non-amplified but has an IHC of 1 with a low oncotype score. Based on this, she ended up being treated with surgery and then tamoxifen as her endocrine therapy in the adjuvant setting. 2 years later, she recurred, and this was while on tamoxifen. So she ended up being treated with letrozole and palbociclib along with ovarian function suppression. NGS was pretty unrevealing and only revealed a P53 mutation at that point. She has disease pretty quickly at only 7 months on letrozole with palbociclib. She has multiple new liver metastases. And our question is, what therapy would you be thinking about choosing for this patient? Okay, well, we were trying to hint in this case that the patient did progress pretty quickly. Really when we see a benefit on CDK4/6 for the first time of less than 12 months, this is really a patient that we think about having endocrine refractory disease, maybe thinking about moving towards antibody drug conjugates at that point. So a little bit of a panel discussion here. We're back to our slide of sequencing. We spent a little bit of time on the left side of the slide really talking about these different mutations for various endocrine therapies. But I may ask Dr. Modi a question if she wouldn't mind. We have both trastuzumab deruxtecan as well as sacituzumab govitecan and datopotamab deruxtecan, another TROP2 targeting antibody drug conjugate. But what do you think about when you think about potentially sequencing these? We don't have a lot of data here, but do you think that sequencing is reasonable, or do you try to put intervening chemotherapy in between?
I mean, that's a question we get asked a lot, and unfortunately, I don't think there's a data-based answer to that question. In general, the ADCs have proven to be a better way of delivering chemotherapy. And so I think for most of us, if we're already treating patients with sequential chemotherapy regimens, there is motivation there to try and use the ADCs. And the problem is the ADCs available today, they have a lot of overlapping similarities. So you have TDXD, which has the same payload as datopotamab. You have sacituzumab and datopotamab, which have basically the same target and similar types of payloads. So I think in general, when I the only way to try and make sense of all of this is doing sort of cross-trial comparisons. And so I think when I think about HER2 low patients, I think looking at the three big studies we have today, Destiny 4, the Tropion-1, and Tropics-02, I do think the weight of the evidence and the efficacy and trying to compare patients that are the most similar across these, TDXD, I mean, using the targeted ADC seems to have the best chance of efficacy. So I do tend to use that biomarker to select for TDXD in the HER2 low patients and now in the HER2 ultra low as well. When it comes to the HER2 negative patients that are IHC 0 today and hormone positive, we do have both sacituzumab and datopotamab based on just recent FDA approval again. And then I tend to look at the safety profile, and I think in general, datopotamab appears to have less GI toxicity, bone marrow suppression, a better interval of delivery, and so it tends to be, in my mind, maybe a preferred therapy for those IHC 0 patients. But sequencing, I mean, would I use sacituzumab post TDXD? I certainly have, and I think right now what we're really lacking in the field is a better understanding of what happens when the ADCs stop working, and ultimately that's what we're going to need to more rationally choose whether we can sequence these therapies or not.
Fantastic. I completely agree with this. So let's get our official answers for this patient that progressed very quickly on AI and CDK4/6. Would you be thinking about further endocrine therapy like fulvestrant or maybe elacestrant, or chemotherapy with paclitaxel or sacituzumab govitecan? Okay, so I think I agree with most of you. 62% saying sacituzumab govitecan, about 20% saying no, I think I would just stick with chemotherapy, but I think very appropriately here, endocrine therapy, not many people answering that. Dr. Schmid, I don't know your experience with the antibody-drug conjugates in terms of adverse events. Do you find these easier to manage in clinic than traditional chemotherapy adverse events?
It's a good question. So what I find often frustrating is when you talk to clinicians who haven't got much experience, you often get the feedback, these are toxic drugs. But actually, if you have a team that knows what to do, the rate and severity of side effects goes down dramatically. For example, with sacituzumab govitecan, we see practically no diarrhea anymore. If we give G-CSF prophylaxis, we have no problem with neutropenia. We also, now that we're treating nausea better with TDXD, that isn't a real problem. If you adjust the dose, fatigue is also much better managed. So in our hands, with the growing experience of the team, I think these ADCs are very well tolerated. But of course, it needs a learning curve. And if people haven't had that learning curve initially, they can be associated with more toxicity. But as with everything new in oncology, you have to learn how to use these drugs, whether it's immune therapy or ADCs. And when you know what to do, they're generally well tolerated.
Yeah, fantastic. That's been my experience as well. I think two of the big tricks is making sure that patients on datopotamab are using steroid mouthwash, and then certainly prophylaxing with, we particularly use a 3-drug antiemetic regimen up front. I think that really cuts down with the nausea with trastuzumab deruxtecan. Anyone else have anything to add before we move on to the next section?
I think I'll jump right in here then. Let's now finally move on to HER2 positive metastatic breast cancer. Of course, this is an arena where trastuzumab deruxtecan and ADCs in general have had a profound impact. So again, starting with the current ESMO guidelines for the treatment of HER2 positive MBC, jumping in actually at the second line setting post the Cleopatra regimen, I think the preferred strategy for most of us today, as listed here, is to use trastuzumab deruxtecan or TDXD, particularly in patients where there are no or unknown or stable brain metastases. More recently, we've seen trastuzumab deruxtecan also be considered an option for patients with active brain metastases alongside the tucatinib, capecitabine, and trastuzumab regimen of HER2 CLIMB. So let's look at the data that has led to this update. So DESTINY-Breast12, this is a global phase 3b/4 trial, so a real-world study. In this trial enrolled patients with HER2-positive metastatic breast cancer who had less than or equal to 2 lines of prior therapy. And patients were enrolled into 2 cohorts. One cohort of patients had no brain mets, and the other cohort were patients who had brain mets at baseline. And that was a cohort of 263 patients. So it's probably our largest prospective experience with TDXD in patients with brain metastases. And shown here is the primary endpoint for that group, which is progression-free survival. And as you can see, the median PFS overall was 17 months, which is actually very similar to what we would expect to see with a similar population without brain mets. So if you think about DESTINY-Breast02, the median progression-free survival in that population was 17.8 months. So already a suggestion here that patients with brain mets can do very well with TDXD. When we look a little more closely at the population itself, about 60% of these patients had stable brain metastases. 40%, on the other hand, had active brain metastases. But regardless of this, both groups do similarly well. So the 12-month progression-free survival rate for the 2 groups is 63% versus 60% respectively. So again, I think a suggestion here that TDXD is active in the CNS compartment. I think even more compelling was the data showing the intracranial response rates with TDXD in this trial. So of course, this was calculated in the patients who had measurable brain mets at baseline. So it's a smaller cohort, but the overall response rate in the CNS was 72%. I think that's pretty impressive. And again, the group that had stable brain mets had an approximate 80% response rate, and those with active brain mets had 62% response rate. Probably some of the most compelling intracranial response rate data we've seen, similar, if not better numerically than even the HER2 CLIMB regimen. So again, to me, this is reassuring that we do actually have activity for this large monoclonal antibody in the CNS compartment. These are the overall survival curves. On the left, it's for the brain met cohort, and on the right, it's for the patients who did not have brain mets on, or the non-brain met cohort, which was comprised of about 240 patients as well. And you can see neither group has actually reached its median OS yet. But if you look at the 12-month overall survival rates, they're nearly identical, 90% in both groups. So once more, I think supportive of the fact that even these patients with brain mets do very well, almost as well as the non-brain met patients. In terms of the safety profile in DESTINY-Breast12, no major differences in the group of patients with brain mets and without brain mets, as you can kind of see pretty clearly here. What was different, however, was the ILD rates. So the ILD rates in the brain met population overall were 16%, which is a little bit higher than the non-brain met population. But I think more concerning was the grade 5 event rate. It was almost 2.3%. In the group with brain metastases. That's double what we saw in the non-brain met population, and certainly much higher than what we are used to seeing in more modern studies of TDXD. And I do think it's worth pointing out this was a real-world trial. So there was no adjudication, ILD adjudication committee associated with this study, unlike many of the other randomized studies we've seen with TDXD. And of course, this is a brain met population, so many of these patients are on steroids, which predisposes to PJP and other opportunistic infections. And certainly there was no mandated prophylaxis for this. And so I do think there may be other reasons why we saw, I think, grade 5 event rates that are a little bit out of keeping with some of the modern trials of TDXD here. With regards to LVF dysfunction or LVEF dysfunction, again, low rates and really no difference between these two populations. So overall, DESTINY-12, I think, as we said, it really does provide support that TDXD is an excellent therapy for HER2-positive metastatic breast cancer patients, regardless of brain metastases. So what else is new on the horizon for this population? Well, we heard about BB1701 earlier. That's being developed both for HER2 low and HER2 positive MBC. Similarly, ARX788, this is another HER2 antibody drug conjugate, again with a trastuzumab-like backbone. It has a non-cleavable linker and a tubulin targeting payload. What's particularly unique is that it has site-specific conjugation or attachment of the payload, which allows for a more reliable, homogeneous, controlled, I think, delivery of the cytotoxic. And so shown here is the schema for ACE-Breast02, and this was a randomized study conducted in China for patients with HER2-positive metastatic breast cancer, comparing ARX788 to lapatinib plus capecitabine. This is a less pretreated population. They had less than or equal to 2 lines of prior therapy. They all had taxane and trastuzumab, but there was no requirement for pertuzumab, TDM1, or TDXD. So a less than conventional pretreated population by today's standards. Shown here are the primary endpoint PFS curves. And as you can see, there is a significant or statistically significant advantage in favor of ARX788 with a hazard ratio of 0.64. And these are the overall survival curves with the trend, again, showing an advantage for the antibody-drug conjugate. Unfortunately, this ADC is associated with I think a more than expected level of toxicity. So about 30% of patients will have ocular toxicity that's grade 3 or higher. And about half the patients had some degree of lung toxicity, ILD or pneumonitis. 7% was high grade. So in general, there appears to be, this could be, I think, a challenging ADC to deliver in the clinic. Nevertheless, we are excited to see the results from ACE-Breast03, which is an ongoing phase 2 trial, this time for patients with HER2-positive metastatic breast cancer who have received prior trastuzumab deruxtecan. So another trial to keep on your radar. So I'll finish this section again with another case, and this is a patient I treated, or I am treating. She's a young woman. Originally was diagnosed 12 years ago at the age of 26 with a locally advanced hormone-positive, HER2-positive breast cancer. She received standard of care neoadjuvant therapy for the time. Unfortunately, again, had a lot of residual disease, so did go on to have radiation. And there was no adjuvant TDM1 at that time, but she did have adjuvant endocrine therapy. Unfortunately, several years later, she did develop recurrence. It was isolated to the biliary tract, sort of a unique case. But she had really tremendous benefit from the first-line Cleopatra regimen with complete resolution of her systemic disease. But while on maintenance HP, she developed brain metastases. And she developed multiple brain metastases. Almost 20 lesions were seen. And surprisingly, she only had very mild neurological side effects. And so given what we know today, I'll pose the question, what therapy would you offer to this patient at this time? And the options, of course, are TDXD, whole brain radiation, the HER2 Climb regimen of tucatinib, cape, and traz, neratinib, cape, or the HER2 Climb 02 regimen of TDM1 plus tucatinib. And I can see the results here in the chat. So almost 50% of you chose TDXD. Another quarter chose the HER2 Climb regimen. And then smaller numbers. But what was, I think, most interesting is less than 10% of you chose whole brain radiation. So I think that's really a great poll from my perspective. There is really no right answer, right? I mean, I think there are some good options, and considering the fact that she really had very little symptoms from her brain metastases, and sometimes these patients who are in systemic remission can live for many, many years with their disease. I think trying to defer the toxicities of radiation are becoming, I think, more and more relevant today. And so, from my perspective, I think two really excellent options are TDXD and the HER2 Climb regimen. And we did end up offering her TDXD. And you can see in the next slide here, she had actually a really impressive response after 2 cycles of therapy. These are the pre and post MRIs, and in fact remains on TDXD now still in complete remission. So she had an excellent outcome. And I think I'll end there and turn over the platform to Nicola.
Thank you, Erica. And I think that when we deal with patients with brain metastasis, one of the most difficult part of our work as diagnostics for biomarker testing is the sampling. And we cannot perform neurosurgery in all centers, even if the specialized centers is extremely difficult to get material from brain metastasis. And that's a fact, of course. But we also have to think about what is the actual real clinical need for retesting the brain metastasis. And in my opinion, this is the question that we should discuss when we discuss the case into the multidisciplinary meeting. At present, we have several types of biomarkers that can be tested for patients' eligibility, as we said before, but we also the possibility of testing the ctDNA on blood samples, plasma samples, more precisely. And also we have the possibility of testing tissues from different time points. And of course, for HER2 testing, we still need tissue, and particularly we may need metastatic tissue, but it is usually extremely rare, the situation in which we do not have tissue samples and we should only rely on sampling from brain metastasis. So in my opinion, if brain metastasis is available in terms of sampling, of course, it's a type of biosource that should enter into the clinical discussion for molecular testing. But at present, I think that we have several diagnostic strategies that we can put in place before coming to the need of sampling from brain metastasis.
So if you talk a little bit more about the management of brain mets, and as you can see here, local therapies is one of the discussion points that has come up after DESTINY-Breast12. Do we still need local therapy? Should we still prioritize it? What are your thoughts on that?
I mean, I think it's an important question now that we have today a lot of systemic therapies that can work really well for brain metastases, particularly for HER2 positive breast cancer patients. In fact, it would be great if we had some of these for our HER2 negative patients as well. As the case I had really illustrates that some of these patients are going to live for a long time, that go into systemic remission. And I think it's tragic to see people develop the late-term toxicities of whole brain radiation. So I think it's fantastic, and I think for cases where there isn't an urgent need based on symptoms for local therapy, I think we've got compelling data today with HER2 Climb, and even with Destiny-12 now to suggest that we can maybe consider our systemic therapies more and more. I think this would be a great space to have perhaps a trial, to compare these two strategies. My sense is it's going to be a combination, of using local and systemic therapies to manage a lot of our patients well.
I mean, I think what we do hardly ever these days is whole brain radiotherapy, as you mentioned in your case. We get away with the large majority of the patients giving stereotactic radiotherapy, gamma knife or cyber knife, and I think with the help of systemic therapies that are more effective there, I wouldn't look at them mutually exclusive. We bring together effective brain penetrating systemic therapy together with local therapy, but avoid whole brain radiotherapy. And I think with that strategy, we now have many patients who live for several years with brain metastases.
Great.
A question that often comes up and was at some point still in the guidelines is what's your should we choose tucatinib or should we choose TDXD in patients with active brain metastasis for HER2-positive breast cancer? Do you have a strong view on that?
Yeah, I think it's very individualized, that decision for me. I mean, kind of have to look and see what else is happening in that patient. So as a s- simple answer, I think it varies depending on the scenario. So for those patients where, systemic disease is also a priority to treat, then I like the idea of TDXD in that population, because it works so well both for the visceral body disease, systemic disease, as well as brain mets. For cases where there's really a low burden or no burden of disease in the body and it's really isolated brain involvement, these are sometimes the patients you see who are on HP maybe nowadays, who may be relapsing without anything systemically. Um, because of I think the excellent tolerability and safety profile of drugs like tucatinib and capecitabine, I'm starting to think about using that more in that kind of a population. So a lot of it really depends on what else is happening in that patient.
Yeah, so so in other words, you look at the extracranial disease as much
Right.
as the intracranial disease, and if you need an active drug in the extracranial disease as well, then TDXD obviously has superior activity there. We've got a question from the audience, and maybe Erica, we can bring you in. That is a question around MRI for the brain. And if I rephrase this a little bit, is it okay to use CT or do we need to use MRI? Or what are your views on that?
Yeah, I mean, I think the MRI is still superior. I mean, I think one of the questions we're starting to grapple with now is, when we enrolled the HER2 CLIMB trial, over half of the brain mets that we found on that trial were not otherwise known. They were found because of the required required brain scan at entry. So the question is, I mean, I don't think we want to be getting, brain MRIs in patients that we don't think have brain mets, every 8 or 12 weeks. But at time of treatment changes, should we move a little bit more towards actually considering looking at the brain and taking that into account when we're picking lines of therapy? Before we kind of took the approach that we didn't want to know in some ways if people were asymptomatic because we didn't really have great treatment options there, but I think this is changing. So if I'm going to really look at somebody's brain, I do tend to order an MRI, and I'm going a little bit more towards having a very low threshold to do that and considering it at time of treatment changes.
And it's probably even more relevant if you want to consider local therapy. So if you want to consider stereotactic radiotherapy, we see often substantially more lesions on MRI than on CT, especially in the sub-centimeters space. Good. If there are no further questions from the audience, then I think it's probably okay to move on. It's now over to me to talk a little bit of where I think we are heading with ADCs in breast cancer treatment in the next few years. I want to cover a few areas: new indications for ADCs, where are we moving with them, then treatment resistance and sequences, new ADCs and combinations. If you look at the current pathway for ER-positive breast cancer, as we had already discussed, I think one of the areas where there's work ongoing with regards ADCs is, are we getting better at defining patients earlier as hormone refractory? And does it make sense for those really poor endocrine responders to, for example, bring an ADC in earlier? We clearly still have to do some work on how best to sequence those ADCs, when to give them, how much target is needed, as we discussed before, but also of combinations. Erica mentioned the trial that uses an immune therapy combination. We'll get back to that in a minute, which I find is really interesting. If you look at HER2-positive breast cancer, again, it's similar questions. Obviously, optimal sequencing of T-DXd. We all are almost expecting that T-DXd will move a line forward, but then it's also the question what happens after T-DXd and what possible combinations are there. And then we are expecting in the next few months to see data in the early disease setting with ADCs, both in the neoadjuvant setting, but also in the post-neoadjuvant setting. And that will raise a number of questions of how we use these drugs then in the metastatic setting. We haven't spoken much about triple-negative breast cancer, but of course we have ADCs there as standard of care at the moment in a second and third line setting. And it is the similar principles as in the other subtypes. We need to work out what's the role of ADC combinations and how do we best sequence those ADCs. We are again expecting ADCs to move in the post-neoadjuvant space and to some degree also in the neoadjuvant space. So if you look at some of the ongoing trials with ADCs in metastatic breast cancer, in triple-negative breast cancer, at the moment divided by PD-L1 positive and PD-L1 negative, there are two, with sacituzumab govitecan and with Dato-DXd, there are for each subgroup phase 3 trials ongoing. The PD-L1 negative trials are expected to read out relatively soon. The PD-L1 positive trials a little bit later. PD-L1 negative ADC versus chemo alone, and PD-L1 positive obviously in combination with an immune checkpoint inhibitor. A trial we are setting up as an academic study is looking actually in PD-L1 negative patients, whether by using an ADC as a major microenvironment disruptor, whether we can turn tumors that are not immunogenic to immunogenic tumors. So we are looking at PD-L1 negative patients, that's Dato-DXd with or without durvalumab, which I think is an interesting hypothesis. And ER-positive breast cancer, you've already seen some of the trials. We have trials with sacituzumab govitecan. We have with a trial called BNT323, the Dynasty breast trial, and we got Trofuse 10 with sacituzumab TMT alone and in combination with pembrolizumab in an early line setting, comparing it to standard chemotherapy. And the trial we are all waiting excitedly, I should say, is the DESTINY-Breast09 trial in HER2-positive breast cancer, T-DXd versus TPH, or our Cleopatra regimen, or the combination of T-DXd plus pertuzumab. And we can discuss whether or not we expect this trial to be positive and how positive it is to ultimately change clinical practice. In the adjuvant setting, for patients who had prior neoadjuvant chemotherapy, there are 3 similar trials ongoing in triple-negative disease. So the same principle: patients had neoadjuvant chemotherapy and immune therapy had residual disease, and then and those patients unfortunately have a 1 in 3 risk of disease recurrence. And I personally think the ADCs are of huge relevance in that group. If you look at the data, Erica and Sean, who shared with you, look at the response rates. One of the, for me, striking features of these ADCs is the extraordinarily high response rate, between 30 and 50% in some of those trials, and several fold higher than, for example, with capecitabine, which happens to be our control arm in this setting. So as we need response in a post-neoadjuvant setting, I'm very optimistic that some of these trials, if not all, may prove positive and lead to a patient benefit. In HER2-positive breast cancer, the extension of the Catherine trial, again using 3rd-generation ADC T-DXd, comparing it with 2nd-generation TDM1, and again looking at the superior efficacy we saw in the metastatic trials for HER2-positive breast cancer. We are very hopeful that we can also improve the standard of care here in the future. If you move to the neoadjuvant trials that are ongoing, there's a number of trials. TROPION-Breast04 is probably the most radical design here, replacing all of the neoadjuvant chemotherapy with Dato-DXd, a TROP2 target ADC in combination with durvalumab, and comparing it with the KEYNOTE-522 regimen. Now, there are other trials in preparation, but there are also some academic studies. For example, the ADAPT-TN3 trial. We haven't really spoken about stage 1 disease, and there is an attempt to replace chemotherapy with ADC. So this is a randomized trial, sacituzumab govitecan versus sacituzumab govitecan and pembrolizumab in stage 1 disease. And another trial that looks at, again, of the WSG, Adaptian-4, that looks at an escalation and de-escalation strategy in patients who have a very good early response to carboplatin and pembrolizumab, reduce the treatment, but patients who still have residual disease escalate early to sacituzumab govitecan and pembrolizumab and randomize this against AC in those patients. In HER2-positive breast cancer, again, we are waiting the Destiny Breast 11 trial later in the year, hopefully, which had complete replacement of chemotherapy with TDXD, and then half replacement, replacing the AC part with TDXD and continuing with TPH and comparing it to the standard dose AC and THP. The second area to briefly cover is resistance to ADCs, and these are interesting. This is interesting work by the Boston group, who took serial biopsies of patients with sacituzumab govitecan, and in a nutshell, they found two different mechanisms of resistance, but they could be seen in the very same patient. So in this patient, for example, they were in the supradiaphragmatic tumor lesions. They found changes in TROP2 binding, which leads to a target resistance, whereas in the infradiaphragmatic areas, they found failed SN38 TOP1 binding and therefore payload resistance. And what we're learning with these ADCs is that some of the resistance is subclonal. It's often subclonal. We see as a result of this now increasingly something called oligoprogression. And it is important to discuss whether we can bring in targeted therapies, for example, for oligoprogression radiotherapy, and then continue with the systemic therapy. We had already mentioned briefly the sequencing data, and in my impression, most of the resistance to the current ADCs is driven by payload and less so by target. And if you look at sequencing data, for example, of TDXD and SG, they're using a very similar payload. You can see in some patients there's still a good benefit, but overall the activity of the second ADC goes down to probably a third, and that highlights the need for having more effective treatments and different payloads. We already spoke about the target expression and that these ADCs seem to be working even in ultra low expression, but one of the areas where there's work ongoing with AI and other pathology methods is to look at the distribution in the tissue. As you can see, if you have two spots of positive disease and in between a lot of target negative disease, those tumors may possibly respond less well than tumors where the positive and negative cells are very much mixed. And although we are saying at the moment the expression of the targets are not necessarily relevant for selecting patients for therapy, if we go one step back and say we probably have one very good shot on goal with a topo-1 isomerase inhibitor ADC, and maybe we need to look in the future into selecting the ADC according to the highest target expression, because of course, if you look at the sacituzumab govitecan data you saw earlier, it was still superior to chemotherapy even in low target expression. But ultimately the response rates and are higher, whether it's topo-1 targeting or whether it's HER2 targeting. And I think if you have only one shot on goal, we may have to consider that in the future. Where's the development going towards in terms of ADC development? There's a lot of work happening on the ADCs, on antigens, but I think the most important area is payloads. And you heard the data with the eribulin payload, which I think is really interesting because it's a non-cross-resistant payload, and there's an urgent need for more non-resistant payloads coming into clinical practice. Final point is really around combination strategies. There are different combinations one could consider. Chemotherapy and ADC is probably less interesting, but of course one can look at cross resistance with the payload. There are some interesting early data of ADC combinations, and that could be interesting in an early disease setting where we have to maximize the response. If we look at combination with targeted therapy, dual pathway inhibition, for example, with a TKI and an ADC, but also the attempt to regulate the surface expression again with TKIs, but it's probably also an area where we may not see as much as we hope to see. Anti-angiogenic therapy can lead to improved drug delivery. The area where I'm personally most excited about is the combination with immune therapy. And there are multiple possible synergistic reasons why this could work, but ultimately it's massive tumor microenvironment modulation we see through the ADCs, and that can increase the response to immune checkpoint inhibitor. And just to back this up with some data, so this is a study called Begonia. We did it first-line triple-negative breast cancer, Data-DXd, TROP2 target ADC with durvalumab, and interesting enough, most patients were PD-L1 negative. Now, if you look at the response rates and PFS in phase 3 studies in this setting, Keynote 355 or Impassion 130, that was about response rate around 40 to 45%, and PFS is around 5 months. So what we see here is a response rate of nearly 80% with a duration of response of 15 months, and that is a very, very powerful signal, and obviously now moved into phase 3 trials. And similar data with sacituzumab govitecan plus atezolizumab, again in first-line TNBC, but this time PD-L1 positive patients. Again, response rates in the high 70%, 77%, with a PFS of 12 months, the median duration of response of 14 months. So where are the future directions with ADCs in breast cancer? I would hope there's a role in first-line therapy, metastatic breast cancer. We will see some of those questions answered already this year. We are integrating ADCs into neoadjuvant and high-risk adjuvant indications. There's a need to study better the target expression and the intensity distribution, but also the dynamics of target expression, how we utilize this from a clinical point of view, how we use target expression for optimal treatment selection, and of course, as mentioned before, different payloads and their relevance for sequential strategies. Finally, combinations with immune therapy is something where I'm very excited to see additional data, ideally also outside the current indications for immune checkpoint inhibitors. Now we got a little bit of time for some questions. Again, I think we got a question here. How has your approach to monitor patients on T-DXd and sacituzumab govitecan over the respective courses of therapy changed as you have gained more experience with these agents? Erica, would you like to start with this question?
Yeah, absolutely. So, I mean, I think what that question makes me think of is particularly maybe ILD monitoring around trastuzumab deruxtecan. You know, it's interesting because the ILD pneumonitis with this drug, we really treat quite differently than we do, say, with checkpoint inhibitors, where we're really not doing much until we see grade 3 ILD. You know, because of these fatal cases that we've seen, it's recommended to withhold drug even for grade 1 asymptomatic ILD pneumonitis. And if you have grade 2 or greater, that's any symptomatic ILD, it's recommended that we not re-challenge. And so what that means is that I really want to capture these cases of ILD before people have symptoms so I can get rid of it and get them back on study. And so practically, I haven't been spacing my scans out quite as long as I maybe normally would for a drug that has the kind of duration of benefit that trastuzumab deruxtecan does. I tend to keep my scans every 3 cycles, so every 9 weeks. That's really about the closest we can get insurance to cover here in the United States is about every 2 months. So I stick with my scans every 9 weeks. They are really trying to capture any grade 1 ILD so I can get them back on trial. In the case of sacituzumab govitecan, I think I'm quite like you. You mentioned really using prophylactic growth factor after day 8. I'm doing that as well. I mean, occasionally there are patients that struggle even between day 1 and day 8. We can think about dose reduction. You can think about, you know, altering the course. If patients live close, you can think of, you know, a filgrastim or a short product. But most of my patients, unfortunately, don't live quite close enough that is realistic for them.
Thank you. And Sean, a question for you. What could practical sequencing look like and a resource constrained setting and with regards to TDXD and TDM1 in HER2-positive breast cancer?
Yeah, I mean, that's a great question, right? I think there are places where you know, you have to use these drugs in a particular sequence in order to have access to all the drugs. And you know, I think we're lucky here where we can choose therapies just based strictly on efficacy. And you know, if you look at the data we have today, I think certainly Destiny Breast 03 is highly compelling. TDXD is the superior HER2 ADC. And I sort of like what you said earlier, if you have one chance on one shot on goal, we want to use our best drugs early. I mean, they work longer, they are more effective, patients do better, especially if we can put them into real remissions. So this is a practical question, I guess, and I think yeah, everyone will have to figure it out given the constraints in their system. The reality is TDXD does work post TDM1. We've seen really good data for that. Do we know about the reverse sequence? I mean, there's anecdotal data to suggest that TDM1 can still work post TDXD. I think it would be really nice to get some more concrete data from longer term follow-up from studies like Destiny 3. But for now, I think if resource is an issue, and you're able to sequence these in a particular way, I do think, you know, I would use either sequence to try and get access to both drugs in that scenario, whether you have to use TDM1 first, or you can use TDXD first and then TDM1 second.
Thank you. We unfortunately have come to the end of this open session. I would like to thank the faculty for fantastic presentations, a great discussion, Medscape for organizing this. For all of you who want to get your CPD credit, click on the Earn Credit icon or visit the Medscape webpage as it is here. Thank you very much.